Hello everyone, welcome to Grill today. The code is kidney and you can text the phone number on the screen, and if you do miss the code then it also will be shown at the end of the presentation. So for those of you that I have not met yet, my name is Courtney and I am currently a first-year clinical pharmacy resident. Many thanks to Jeff Fish, who is my content expert and helped me put together these slides. I will be reviewing continuous renal replacement therapy, otherwise known as CRRT, and really review the pharmacokinetics behind it and how we would adjust the medications. I chose this topic because it was one of the topics that I had the most questions about when staffing, especially when we do have patients that transition between different modalities of renal replacement therapy and how to either adjust the medication dose or hold the medication. So I really wanted to do some digging in order to really determine tips for how to adjust the medications and then how to verify the supplemental orders as well. So throughout my presentation over the next hour, I will be comparing the different modalities of CRRT in addition to comparing CRRT to other renal replacement therapies to determine potentially when we would use CRRT compared to intermittent hemodialysis. And then once we do look at the different pharmacokinetic modalities of CRRT to see how we will affect the drug dosing and how we would potentially need to increase the drugs to make sure that the patient is receiving an adequate dose of the medication. And finally, to really review the process for verifying supplemental orders with CRRT new starts, as there are many different orders that go into place when a patient is being started on CRRT. To provide a broad overview for renal replacement therapy and when we would have a patient that does require this. So it does not just include a patient with an acute kidney injury. There really needs to be one of the below indications that suggests that the patient would benefit from renal replacement therapy. The acronym that I did learn during school that really has helped me remember it even outside of school too is AEIOU. So the first one is acidosis. If we do have a patient that has severe acidosis that is either severe or refractory to medical management, then we may consider using renal replacement therapy, specifically if the pH is less than 7.1. We may also use renal replacement therapies if there are electrolyte imbalances. So the electrolytes that I think of specifically are hyperkalemia, as hyperkalemia can lead to cardiotoxicity and arrhythmias. So especially if a patient has a potassium greater than 6.5, we may consider using renal replacement therapy. But we can also use this if a patient does have severe hyponatremia, hypernatremia, or hyperphosphatemia, and these are all electrolyte imbalances that may be associated with either AKI or CKD. If a patient does present with intoxication, we are able to use replacement therapy to draw out these intoxications for specific medications. So specifically for medications that are smaller and non-protein bound molecules would be able to be removed by renal replacement therapy. The drugs that I think of, at least initially, are lithium, toxic alcohols, and salicylates. We are also able to use renal replacement therapy in a patient that is volume overloaded. So if they do have a substantial amount of volume overload, or if they are refractory to diuretics, we can use this. And then finally, if a patient has uremia, such as encephalopathy and pericarditis, then we may suggest that the patient can benefit from renal replacement therapy. To look at the specific patient factors that would determine when we would start renal replacement therapy, I do have a patient case that I will be sharing now and then providing some questions throughout the presentation. So our patient is a 48-year-old female who presented to the TLC with septic shock. She was intubated and initiated on CRRT due to acute kidney failure. For her pertinent labs, her sodium was 128, potassium 6.2, serum creatinine 4.23, and lactate of 6. The pertinent medications that are especially important that we would want to at least acknowledge for starting her on CRRT are the norepinephrine for septic shock and then empiric antibiotics of cefepime, metronidazole, and linezolid. So when looking at our patient case, how would we decide if either intermittent hemodialysis or CRT is the best option for her? To really provide a broad overview comparing the two different renal replacement therapies, intermittent hemodialysis does occur more rapidly over 3 to 5 hours. So it is better for patients that either have an acute intoxication or do have any severe electrolyte abnormalities that do need to be corrected pretty rapidly, because it does have that rapid solute clearance. It also permits patients to be mobilized, so it may be preferred in more of our IMC or general care patients that are more stable and do want to participate in either PT or OT throughout the day. However, for our patients that are hemodynamically unstable, so our patient case DB, it may worsen their hemodynamic instability, so CRT may be preferred because it does provide more of a slow and continuous renal replacement. CRT is also more effective at achieving the net fluid balance than intermittent hemodialysis, and it has been shown to be preferred in patients with hepatic failure or brain injury due to increased intracranial pressure. However, when comparing intermittent hemodialysis to CRT overall, there has not been a mortality benefit, but like I said, it is preferred in patients that are hemodynamically unstable. And then to jump into CRT, so we have 3 different modalities of CRT. We have CVVH, CVVHD, and CVVHDF, and break down the acronym for what these letters stand for. So the first letter is continuous because the CRT is running ideally 24 hours a day. The CRT can either have venous or arterial access when looking at how it's leaving the patient or returning to the patient. So we would be able potentially to have arterial access, but it does require to use the patient's systemic blood flow, so it's not optimal in hypotensive patients. So primarily we do use venous access in our patients with CRT. And then finally, the last letter is signifying the mode of dialysis. So we can either have patients on CVVH, CVVHD, or CVVHD. And at UW, we do primarily use CVVH. To really break down the different modalities of CRT to see how these different modalities work. So I do have a diagram of the different modalities of CRT in addition to intermittent hemodialysis. On the top left corner of the screen, it does have continuous hemofiltration, or the CVVH, that is primarily used at UW. So the blood is coming outside of the patient and then through the membrane and goes back into the venous access site. In continuous hemofiltration, there is an ultrafiltrate that is generated across the membrane, and there is an excess ultrafiltrate that is desired for negative fluid balance. We replace this excess fluid that is being taken out with replacement fluid, and the replacement fluid can either be delivered before the filter or after the filter. There is no dialysate solution that is required, and the solutes are really driven out through the effluent port by the pressure gradient. In the top right corner of the screen is continuous hemodialysis, or CVVHD, and this is similar to intermittent hemodialysis, but it is running continuously over ideally 24 hours. The dialysate solution does run in the opposite direction of the blood flow, and the effluent consists of both the dialysate solution that is spent in addition to the volume of the ultrafiltrate. In the bottom left-hand corner of the screen is a mixture of both the hemofiltration and the hemodialysis, so it's CVVHDF. It does require both a dialysate solution and a replacement fluid in order to replace these fluids that are being lost in the dialysis. So similar to hemodialysis, the dialysate is being perfused on the opposite direction that the blood flow is, and then the effluent is also being drawn out by the pressure gradient as well. And then the bottom right-hand corner of the screen is for intermittent hemodialysis. So it works by also having a dialysate solution, but as I said previously, this does just occur over 3 to 5 hours. To go into specifically how these different modalities work to draw out solutes and fluids, to first look at CVVH, or the modality that we do use primarily at UW. So it does work by hemofiltration or convection. This means that it forces a movement of fluids out along with the dissolved solutes. It can be used to either remove both the fluid and the solutes. Because it does work by convection, as long as the solutes are able to physically pass the membrane, they are able to be cleared, but solute removal can also be affected by high membrane permeability, molecular size, degradation of the filter membrane, and then the replacement fluid flow rate. So the faster the flow rate, the more solutes and fluids would be cleared. For CVVHD, or continuous hemodialysis, it does work by diffusion. So the solutes move from an area of higher concentration, as shown in the diagram, to an area of lower concentration. Because of this, it more easily removes the smaller solutes, and the diffusion rate is inversely proportional to the molecular weight. Larger solutes, such as vancomycin, may be less efficiently removed in this modality of CRRT. And then the solute removal is also affected by the dialysate flow rate. Again, the faster the flow rate, the more would be cleared, the molecular size, and also the permeability of the filter membrane. As I said, the CVVHDF combines both a convection and diffusion, so it does remove more solutes and fluids than either the CVVH or CVVHD alone, but it does require both a dialysate and replacement fluid, so it does require more coordination with pharmacy to supply these bags, and also the nursing staff as well to adjust these rates. Before I go into how we would adjust the drugs, or how we would adjust medications to accommodate for these solutes being drawn out with a CRRT, I first wanted to just provide a broad overview of the altered pharmacokinetic parameters in critically ill patients, as we are most commonly using CRRT in critically ill patients that are often hemodynamically unstable. And in addition to the CRRT affecting the pharmacokinetics, there are also multiple different factors that may affect the pharmacokinetic parameters as well, so it's not as easy to estimate exactly how the drugs are being cleared. For example, critically ill patients may have severe systemic illness that is affecting multiple different organ functions, so they may have, in addition to acute kidney injury, also have acute liver injury as well. Oftentimes in our critically ill patients, they also have been receiving a lot of fluid resuscitation that could be affecting their volume distribution. In addition, patients that are on extracorporeal organ support, or ECMO, do have altered pharmacokinetics, so this can really affect the volume of distribution, and drug clearance as well. Critically ill patients may also have altered protein concentration and binding that does affect our drug clearance. In patients with AKI, they do oftentimes have lower protein binding due to kidney failure or low albumin. So these are just many different pharmacokinetic parameters to also evaluate in our patients to determine appropriate doses for our patients. And now I will transition into the factors specifically that affect CRRT drug clearance. So as I mentioned previously, for molecular weight, especially in the modality that we use at UW for the CVVH, as long as the drugs can physically pass the membrane, then they're able to be cleared. So drugs that are less than 4,000 Daltons are easily able to be removed by CRRT. And most of the drugs that we do use are less than 4,000, so usually molecular weight is not a factor that does prevent drug clearance. But when we do use the hemodialysis, the drugs that do have a smaller molecular weight are more readily removed by the CVVHD or CVVHDF, and then drugs with a larger molecular weight may be less removed by CRRT. The volume of distribution, as I said, critically ill patients may have an altered volume of distribution that may be even affecting their clearance of drugs. Drugs that do have a larger volume of distribution are less effectively removed by CRRT. So this includes drugs that are lipophilic and highly tissue-bound drugs, as they're receiving less exposure to the filter membrane, so they're not able to be as cleared as efficiently as drugs that are remaining in the intravascular space and do have that exposure to the filter membrane and are able to be cleared. CRRT does also only remove unbound drug. So in our patients that do have altered protein binding, then the drug clearance will also be affected. Factors that affect protein binding in addition to patients with an AKI that may have a low albumin include pH, the molar concentration of the protein and drug, the presence of other drugs that may displace the protein binding, and also the amount of free fatty acids, heparin, and bilirubin. CRRT features may also affect the drug clearance. As I said previously, the faster the rate of the CRRT is, the more drugs will be cleared. So this includes the ultrafiltration rate, the dialysate, and the effluent rate. Drugs that sequester to the membrane of the CRRT machine may also affect dosing and rapidly clear the medication. However, the only medication that has really demonstrated sufficient binding to the CRRT membrane is colistin, and we do need to empirically increase the dose of the colistin to account for the sequestration. It is not as much of a factor when dosing our other medications, as they do not significantly sequester to the membrane. In our patients that are receiving either the CVVH or the CVVHDF, the type of replacement fluid does affect the clearance of the CRRT or the solutes in the fluids. So when we look at the pre-filter versus post-filter replacement fluid, if a patient is receiving the pre-filter replacement fluid, drugs are cleared at a lower rate because the concentration of the solutes is being decreased just prior to convection across the filter membrane, versus if a patient does have the post-filter replacement fluid, the solutes are cleared and then diluted by the replacement fluid. Some more solutes are being cleared if we do have the post-filter replacement fluid. We also need to evaluate any interruptions of treatment to determine if potentially we need to decrease the dose or hold the dose to prevent overdosing if the patient is not receiving the CRRT for a substantial period of time. For example, when I was staffing, we did have a patient that was on CRRT and ECMO, and they were also on vancomycin. The patient's vancomycin trough did end up coming back at 40 when their goal was 15 to 20. It did appear that the patient did have the trough drawn at an appropriate time, but after talking with the nurse, we did identify that the CRRT was paused for about 6 to 8 hours when they were in the OR. So we were able to dose adjust the medication based on this factor. So it is important to really monitor and make sure that the nurse does notify pharmacy if there are any significant interruptions of treatment that are greater than a couple hours. So when we do look at our medication drug dosing, there are overall 4 different options that we can do for our medications. So we can either not change the dose of the medication at all. This would be for medications that are not cleared renally, so we don't expect the doses to also be cleared through CRRT. This would include medications that are primarily cleared by hepatic or the GI system, so we don't expect that we would need to change the dose in a patient with AKI and subsequently in a patient on CRRT. For some medications, we're able to titrate based on clinical response. So this may include vasopressors for pain and sedative medications. For example, if a patient is on propofol, we're easily able to start at the initial dose and then adjust based on the RAS score. So it's not as necessary to empirically dose adjust just for the CRRT. The most accurate way to dose in critically ill patients is to look at therapeutic drug monitoring. And this really identifies the changes in pharmacokinetic parameters, and we're easily able to evaluate how the medication should be adjusted in order to reach, for example, the goal trough. But like I said previously, this does still require some clinical judgment, especially with our patient that I talked about briefly on the vancomycin and CRRT, to really determine any interruptions of treatment and how we can adjust the medication to make sure that they are receiving the adequate dose. It does also suggest that if we do receive, for example, a vancomycin trough in a patient that did have the trough drawn at an appropriate time, if this trough does end up coming back low, it may suggest that the patient is clearing medications more rapidly than what we originally expected. So we may consider empirically dose adjusting other medications as well. In medications that we're not able to monitor the therapeutic drug levels, we can also calculate a dose with a CRRT clearance and adjust the medications empirically based on estimated equations. So then to review and go back to our patient DB, which medication requires an empiric dose adjustment for CRRT? So you can put your answer in the chat. Answer A is norepinephrine, B, metronidazole, C, cefepime, and D, linezolid. And yep, that is correct, that cefepime would require an empiric dose adjustment. So a good rule of thumb is any medications that are renally cleared and we would expect to dose adjust for intermittent hemodialysis, we would also likely need to adjust for CRRT as well. And then these are just some examples without CRRT dose adjustments that we would likely just continue with the same dose. So some medications that I see frequently are ceftriaxone, clindamycin, linezolid, and metronidazole, where even if a patient does transition between renal replacement therapies, we would be okay with keeping with the same dose of the medication. In our medications that we do need to dose adjust for CRRT, I did put in some general dosing principles before we go into the actual equations. So because a patient is on CRRT, the serum creatinine is not an accurate way to measure their clearance of drugs. So we should not be using the serum creatinine to calculate their kidney function. In patients that do still have urine output, this may be a good way to measure any residual kidney function that they do have. So if a patient does have a significant amount of urine output, then we may decide to increase the dose even more to account for the clearance that is the clearance of the medication from the residual kidney function. In patients with CRRT, especially in critically ill patients, it is important to really consider dosing on the higher end of the range to avoid underdosing and make sure that, especially for antibiotics, we are treating the infection appropriately and to account for the clearance from the CRRT. And finally, to really reduce the dose when the CRRT is stopped. So provide that adequate dose to the patient, but also know when to decrease the dose in order to prevent overdosing. And as a general recommendation, that the dosing recommendations that I will be going over should be used as a guide in order to recommend dose adjustments, but they aren't a final answer. So clinical judgment should still be used in order to determine the adequate dose for your patient. To provide a review of the CRRT dosing resource, which I'm sure that many of you have used previously. So this dosing resource is listed under the pharmacy dashboard in HealthLink under the renal links, and it's titled CRRT dosing table. So there are a couple different boxes that you would put numbers in to fit your patients. So you can put in the replacement fluid rate and then also the patient weight, and it does populate the different pharmacokinetic parameters and would recommend a CRRT dose for your patient. For the replacement fluid rate, you can find this by going into the patient's MAR and seeing the fluid rate that is being charted on and put that in this Excel document in addition to the weight. It does provide many different pharmacokinetic parameters. And then looking at the anuric dose, seeing based on the parameters how much we would need to increase the CRRT dose to make sure that they are receiving an adequate dose and we aren't underdosing them. There are additional dosing resources that you would be able to use as well. When I do dose a patient with CRRT, I often like to look at some other resources as well, just to verify that the dose that I choose does match up or is similar to other dosing recommendations. Lexicomp does have recommendations based on high flux dialyzers, which is primarily all CRRT machines, and the effluent flow rates of 20 to 25 milliliters per kilogram per hour. So on our patients that are on the standard flow rates, we are able to use this Lexicomp recommendation. If a patient does have a faster flow rate, then this may not be as accurate as they may have a larger drug clearance that Lexicomp is suggesting. It does group the dosing of CVVH, CVVHD, and CVVHDF together. And like I said previously, CVVHDF does have an increased drug clearance, but it has been suggested by some experts that this increase in clearance is not significant, and we may still be able to start with the same empiric dose in the different modalities. The UC Davis resource does contain loading doses for CRRT and does recommend the maintenance dose based on the modality. So this could be a good resource to look at if you are concerned that, for example, CVVHDF would have a greater drug clearance than a patient on CVVH. The UNMC resource does also have the loading dose as well, and then the dose based on the CVVH dialysate flow rate. So if we do have a patient that is on a higher flow rate, we're able to look at this and determine how we would adjust the dose for that. And then the University of Michigan does have a CRRT dose for a standard flow rate of 2.5 liters per hour. So these are just a couple examples of dosing resources and charts that you may be able to use in order to really estimate the appropriate dose for your patient. Going back to really calculating the clearance and looking at the equations that we have used for our dosing document. So there is one method to calculate clearance that I was initially looking at, and this is the clearance that's recommended by UpToDate. They do recommend that, or suggest that the effluent rate is equal to the CRRT drug clearance, but this does not include body weight, so it may not accurately represent the drug clearance, especially in extremes of body weight. So even though there are some resources that do recommend this, it may not provide as much of an accurate recommendation that we're hoping for. To look at the drug dosing equations that we do have and we do use at UW to create our dosing chart. So there are a couple equations, and I don't expect anyone to memorize this, but I wanted to at least review it briefly in order if you do have questions for future medications that you're able to refer to this PowerPoint. To calculate the total clearance for the medications, we look at the total body clearance equal to the renal clearance, or the clearance by the CRRT machine, and the non-renal clearance. So to look at the non-renal clearance that is separate from the clearance from the CRRT machine, we would take the volume of distribution times the elimination rate constant. And in our patients that are on CRRT, it is preferred to use pharmacokinetic parameters that are specifically for dialysis patients, as this may be more accurate than pharmacokinetic parameters that are listed in the manufacturer insert for healthy patients. For example, when we are looking at acyclovir, the half-life in adults with normal renal function is 2.5 hours. but in patients with hemodialysis, the half-life is 5 hours. So it is better to really use those pharmacokinetic parameters that are specific for our dialysis patients if it is possible. Because CRRT patients frequently have an increased volume of distribution due to fluid status or altered physiology, it is really recommended to have a load if possible to really make sure that the patient is receiving an adequate dose upfront and we're able to really fill the tank. When looking at the clearance by the CRRT machine itself, so we can look at the solute-specific siphoning coefficient times the ultrafiltration rate. For the siphoning coefficient, it is really the ability of a solute to cross the membrane, and it can be estimated by using the protein binding or the unbound fraction of the drug that's able to cross the membrane, as only the unbound drug is able to be cleared by CRRT. The siphoning coefficient really remains approximately constant in CVVH, so we can really be confident that the unbound fraction of the drug does provide an approximate number for the siphoning coefficient. We do times that by the ultrafiltration rate. As the faster the rate is, the more solutes and fluids will be cleared. As I said previously, the fluid replacement does differ or does change the solute clearance when we are looking at pre-filter versus post-filter replacement. So patients that do have the post-filter replacement fluid may have an increased amount of solute clearance, but this may not be significant, and we may still be able to really use the same empiric dose for both pre-filter and post-filter. And then finally for the equation, so we look at the clearance by CRRT divided by the total body clearance. And then this gives us really the maintenance dose multiplication factor. So this factor is used to times by the anuric dose in order to ensure that we are accounting for the solutes that are being taken out by CRRT. So even if a patient does not have any residual kidney function, we are accounting for the solutes that are being taken out by CRRT. And as I said previously, in our patients that do have some residual renal function or do have urine output, we may consider even empirically increasing the dose of the medication to account for the clearance that they do still have by their residual kidney function. So then just to review and go back to the CRRT dosing resource that I showed previously. So this does have the different pharmacokinetic parameters and does calculate the usual CRRT dose that I did review the equations for. So as a review, all that you need to do in order to determine the CRRT dose would be to enter in the replacement fluid rate and then the patient weight as well. So as a review for my assessment question number 2 and going back to the patient case, what should be taken into consideration when dosing our patient's FFP? So you can put your answer in the chart. Answer A is the UW dosing chart. B is residual renal function. C is severity of illness. And D is all of the above. And yep, you guys are all correct that D is correct, that all of the above should be taken into consideration. So even though we have this thorough chart to look at that it does have a recommended CRRT dose, it should also require clinical judgment as well to look at the severity of the illness. If the patient is critically ill with an infection, then we may consider dosing higher empirically just to make sure that they are being covered and receiving an adequate dose of the medication. Now that we have talked about how to adjust medications, I wanted to go into some of the supplemental orders that you may see with CRRT. So the first one being anticoagulation in CRRT. So because of the turbulence of blood flow moving through the tubing and the circuit, there is an increased risk of clot. So it is necessary to have anticoagulation in order to help prevent these clots. When we do use anticoagulation and help prevent clots, we are able to really provide a lot of benefit to the patient by maximizing the CRRT time. Sometimes it does take a couple hours to replace the filter membrane if there is a clot. So if we do help prevent that, then we would be able to maximize the therapeutic time that the patient is receiving. We are also able to minimize the blood loss and the need for transfusions. So if there is a clot in the filter, then blood is stuck in the tubing, then it's not able to return back to the patient. So this may lead to blood loss. And just to review, providing anticoagulation does really help decrease this blood loss and then maximizing the CRRT time. So there are a couple different options that we would be able to use in order to prevent blood clots. We're able to use saline flushes, heparin, and citrate. Primarily at UW Health, we do use saline flushes, at least initially in our patients. And then if a patient does clot with the saline flushes, then we may decide to either try heparin or citrate. With the saline flushes, it does decrease the rates of bleeding compared to heparin because it is not systemic and doesn't increase the bleeding risk. However, it does decrease the lifespan of the filter compared with the other agents. When we do have saline flushes as the anticoagulation, the filters do often have to be changed every day compared to with heparin, filters may need to be changed every other day, and with citrate, every 3 days. So citrate really has the longest lifespan of the filters. Saline does have the decreased lifespan of the filter, but it does not have the same risk of bleeding that the other two have. At UW Health, our workflow is to use normal saline and flush 200 milliliters every 1 hour to help prevent clots. In a patient that does have a clot with a saline flush, we're also able to switch to unfractionated heparin that can either be infused regionally or systemically. So some of the pros are that it is widely available and can be monitored to determine the effectiveness. So we can either use APTT or anti-factor 10A. It does have a short half-life and is fully reversible with protamine, so it may be an attractive option for a patient that potentially would need to have the anticoagulation reversed immediately. But some cons is that, especially if we do use the heparin systemically, it can cause some systemic bleeding. And there is a risk for HIT, or the heparin-induced thrombocytopenia. In critically ill patients, they may also have reduced concentrations of antithrombin 3, which may lead to heparin resistance. So in our critically ill patients with CRRT, we may see resistance due to these decreased concentrations of antithrombin 3 and decrease the rates or the effectiveness of anticoagulation. The last option that I wanted to review is citrate. So citrate works by chelating the free calcium in the CRRT circuit. As you can see on the left-hand side with the coagulation cascade, there are many calcium-dependent procoagulants, and citrate chelates this calcium to help prevent the coagulation cascade from continuing. Because it is chelating to the calcium, it does require systemic calcium infusions to help prevent hypocalcemia. It also has a local action, so it does have decreased risks of bleeding compared to heparin, and it does not have the same risk of thrombocytopenia or risk of HIT. But there are several cons that may be associated with a citrate, especially if it is not as familiar with either the nursing staff or any physician monitoring the citrate. So it is necessary in order to really have a protocol in place that helps prevent any errors. We may see electrolyte abnormalities with the citrate because the citrate solution is very concentrated. You may see hypernatremia. In addition, hypocalcemia may be present if we are not replacing the calcium. Hypercalcemia may also be present, and hypomagnesemia. Citrate toxicity can also result in metabolic alkalosis or metabolic acidosis. The citrate, once it does chelate to the calcium, it is metabolized by the liver, skeletal muscle, and kidney. So in patients that do have, for example, hepatic failure or cardiogenic or septic shock, they are at increased risk of citric toxicity because they're not able to metabolize the citrate complexes. In order to determine citrate toxicity in our patients with CRT, we're able to look at the total calcium compared with the decreased ionized calcium. If there is an elevated total calcium but a decreased ionized calcium, then this suggests that there is more of those, or that there are more of those complexes of calcium and citrate that may be accumulated and not being metabolized. Acidosis can occur if there is failure to metabolize the citrate into bicarbonate, and it can lead to continual losses of bicarbonate and calcium citrate complexes in the dialysate filtrate. There can also be conversion from acidosis to alkalosis from the accumulated citrate. In order to really prevent citrate toxicity, it's necessary that everyone being involved with the citrate is knowledgeable with the risk and how to appropriately monitor this. In addition, the dialysis, citrate infusion, and calcium infusion should all be started and stopped at the same time. So if there is a supplemental order for citrate, to ensure that this is not started right away, even before the CRT is started. And then my final assessment question is, what anticoagulation provides the longest lifespan for CRT filters? Answer A is heparin, B, saline flushes, C, citrate, and D, they are all equal. There is no difference. And yes, that is correct that C does provide the longest lifespan for the CRT filters, but it does have the really greatest risk for errors. To finish out my presentation, I will just be briefly reviewing the additional supplemental orders that you may see when starting a patient on CRT. So because CRT is removing both fluids and solutes, it can also cause electrolyte abnormalities. Hypophosphatemia or low phosphate is the most common result. So you will see scheduled potassium phosphate or scheduled phosphate to help prevent this from occurring. Other abnormalities that may be seen but are less common are hyponatremia, hypernatremia, and hyperkalemia, especially in our patients that do also have CKD and may have either potassium or phosphate binders. It's important to address these when CRT is started. For example, if a patient is being continued phosphate binder, it likely needs to be stopped, as the CRT will cause removal of the phosphate. In order to help prevent any electrolyte abnormalities, we do have the replacement fluid bags do have electrolytes in them. So we do have next stage replacement fluid bags that either contain calcium and non-calcium bags. In these bags, there is often potassium bicarbonate and sodium to help prevent these electrolyte abnormalities. When verifying these orders, 4 bags should be dispensed upon verification. Each bag lasts 4 hours, so the nurse hangs. So the nurse only has to hang the bags once a shift. So dispensing the 4 bags allows the nurse to just change it once during their shift. Some supplemental orders that you may see are the anticoagulant citrate compound in order to lock the port of the CRT catheter when it's being disconnected. And like I said, because it does cause a decrease in phosphate, then you will see likely the scheduled Fosnac packets. Typically, this is ordered for 2 packets 4 times a day with holding instructions that the nurse is able to identify when this medication would not be necessary. For example, to hold these packets if the phosphate is greater than 4, the potassium is greater than 5. And then finally, for anticoagulation, the sodium chloride bolus will also be ordered every 1 hour as needed. To provide a review of the key recommendations that I have discussed today, A good rule of thumb is that if there is a medication that is cleared renally and we would expect to adjust the dose in intermittent hemodialysis, we likely would also need to adjust the dose for CRT. So I would recommend pulling up the CRT dosing guide in HealthLink in order to determine the appropriate dose that we would need for our patient. Although these dosing guides are there as a reference, they really should not be used as a definite answer. So it's recommended to really evaluate the clinical status of the patient, look at any urine output that may be suggesting any residual renal function and their volume status in order to really suggest an appropriate dose for your patient in order to avoid underdosing. And finally, anticoagulation is necessary to prevent clots. So this can either be the Saline Flushes, Heparin, or Citrate. Those are my references, and I would be happy to answer any questions. It doesn't look like that there are any questions right now, but feel free to email me if you do have any questions, and thank you for attending.